So hi students, hope you're all doing good. In this video, we are going to discuss about fetal growth restriction. So our topic for today is fetal growth restriction. And first of all, I want to discuss with you some of the definitions. Okay, so we have some terms, namely LBW, that is low birth weight. So this is given when the birth weight of the baby is less than 2500 grams. Okay, and we can also have very low birth weight babies. Here the birth weight is less than or equal to 1500 grams. Okay, and then we have extremely low birth weight babies. Okay, so here the birth weight will be less than or equal to 1000 grams. Okay, so remember, these definitions are given only according to the birth weight and the gestational age is not considered. So the baby can be a preterm baby or a term baby or a postterm baby, right? Now we'll see what is IUGR, that is Intrauterine Growth Restriction or Fetal Growth Restriction. Okay, so here this definition is generally used by the obstetricians. Okay, so this describes the pattern of the growth of the baby in utero over a period of time. Okay, so pattern of growth in utero over a period of time. Okay, so what is going to happen in this type of growth restriction is that there is some pathological process involved. So what happens is the fetus is not going to attain its genetic growth potential, and that may result in perinatal mortality or morbidity, right? So what happens in fetal growth restriction is that there is some pathological process involved and that will be stopping the baby from attaining its genetic growth potential, and there will be an increased risk of perinatal mortality and morbidity. Okay, so generally if you see during intrauterine life in these babies, you will be able to see some features of abnormal fetal Doppler, or there can be AC circumference less than 10th percentile. Okay, so after birth what happens is the estimated fetal weight can be less than 10th centile, or sometimes it can be even less than 5th centile. And definitely when this falls to this level, less than 5th centile, it is going to be associated with more adverse outcomes in the baby. Yes? So what does the term SGA means? SGA means small for gestational age baby, and this term is mostly used by the pediatricians, and this defines a point on growth curve. Okay, we'll be specifically pointing at one point of time. Okay, growth curve, right? So what do you mean by that? In another words, it is a postnatal definition. Okay, and then here the estimated fetal weight or the AC circumference is less than 10th centile for gestational age. Okay, there is also a term severe SGA used when the estimated fetal weight is less than 3rd centile for gestational age. Even you can consider AC along with this. So estimated fetal weight or AC less than 3rd centile, it will be known as severe SGA, right? Okay. So next I want to discuss what are the etiologies of this fetal growth restriction. So etiology of fetal growth restriction includes maternal causes, like there can be hypertensive disease, or there can be pre-gestational diabetes. Then she can be a case of cyanotic cardiac disease, or there can be history of autoimmune disease. Then there can be any restrictive pulmonary disease, or this is also commonly seen in women who are living in high altitudes, okay, that is more than 10,000 feet. Then suppose if there is a tobacco or substance abuse, and then suppose any malabsorptive diseases there. Okay, so these are some of the maternal causes for FGR. Now we'll see some fetal causes. Fetal causes include teratogenic exposure, okay, any kind of drugs, toxins, or even infections. Then there can be infections, and there can be genetic disorders or presence of structural abnormalities, right? Then we'll see some placental causes also. Placental causes include any primary placental disease or abruption or placenta previa or placental mosaicism. Understood? So these are some of the etiologies of fetal growth restriction. Now, the risk factors that are leading to fetal growth restriction can be classified into two types. One set is major risk factors, another set is minor risk factors. Okay. So if we see the major risk factors, these include maternal age, more than 40 years. Then there is a history of paternal SGA. Then there is smoking or cocaine abuse, or there is a daily history of daily vigorous exercise, previous history of SGA baby or stillbirth. There is chronic hypertension, or there is diabetes with vascular disease. So diabetes with vascular disease, or there is renal impairment, APLA, that is antiphospholipid antibody syndrome. Then there is Papa value less than 0.4 multiples of median. Okay, so these are some of the major risk factors. Once again, I will come up. So, major risk factors for fetal growth restriction include maternal age more than 40 years, paternal SGA, smoking, cocaine, daily vigorous exercise, previous history of SGA or stillbirth, chronic hypertension, diabetes with vascular compromise, renal disorders, APLA syndrome and Papa value less than 0.4 multiples of median. Clear? Yes. Now, we will see some of the minor risk factors. So, minor risk factors include maternal age more than or equal to 35 years. Then there is a IVF singleton pregnancy. Then suppose the BMI of the mother is less than 20, or there is low fruit intake pre-pregnancy, and suppose the pregnancy interval is less than 6 months, and also if there is a long gap, for example the pregnancy interval is more than 60 months. So all these are going to cause fetal growth restriction, right? Okay. Now, generally if we see the normal intrauterine growth pattern, can be classified in 3 stages. Okay. So we'll take it as stage 1, stage 2 and stage 3. Okay. So what is happening in stage 1 is there is hyperplasia alone, and this will be happening between 4 to 20 weeks of gestational age. So in stage 2 there is both hyperplasia and hypertrophy, right? And this will be seen between 20 to 28 weeks. And in stage 3 there is only hypertrophy, and this will be seen after 28 weeks, that is 28 weeks to delivery, that is 40 weeks of gestational age. Clear? So this is how the normal intrauterine growth pattern is going to occur. So if you see IUGR, that is intrauterine growth restriction, it can be classified based on the morphology or the onset period. Okay. So morphology types include symmetrical IUGR and asymmetrical IUGR. And based on the onset of IUGR, it can be further classified into early onset type and late onset type of IUGR. Early onset type means that will be occurring less than or equal to 32 weeks, right? And late onset means it will be occurring more than 32 weeks. Clear? So first we'll see the difference between symmetrical and asymmetrical IUGR babies, right? So if we take symmetrical IUGR and asymmetrical IUGR. So symmetrical IUGR is also known as type 1 IUGR, whereas asymmetrical IUGR is also known as type 2 IUGR. Okay? And the incidence of symmetrical IUGR is around 20 to 30%, whereas in the remaining cases, that is around 70 to 80% of the cases will be seeing asymmetrical IUGR. Okay? And remember, the onset in symmetrical IUGR usually starts early, maybe in the first trimester itself. Whereas in the late onset, suppose if it's happening in the second or in the third trimester, then there is a chance of asymmetrical IUGR. Okay. Etiology that is leading to symmetrical IUGR include congenital infections, teratogens, and chromosomal abnormality, right? Whereas in asymmetrical IUGR, most of the times it will be due to uteroplacental insufficiency, or there can be maternal malnutrition, or there can be maternal hypertension. Clear? Right. And then what is the pathophysiology that is leading to symmetrical IUGR. Pathophysiology includes, there is impaired cell division. Okay. So next one, why does this symmetrical IUGR happens? What is the pathology? See, there is impaired cell division in symmetrical IUGR. So what happens is, obviously the number of cells, that is the cell number, is reduced. Okay. And remember, when it happens in this way, this is going to be a irreversible type of IUGR. Clear? And what is the pathology in the asymmetrical IUGR? This happens mostly due to impaired cell hypertrophy. Yes. Okay. So, what happens here? Cell size is reduced. So, since the cell size is reduced, this can be reversible also. Clear? Now, what are the clinical features that you will be seeing in the symmetrical and asymmetrical IUGR? In symmetrical IUGR, head and abdomen are affected equally. Okay, so that's why they call it as a symmetrical IUGR. Okay, whereas in asymmetrical IUGR, they are not equally affected. Okay, and if you see the prognosis of symmetrical IUGR, the prognosis is poor, whereas since asymmetrical IUGR is reversible, the prognosis is going to be favorable. Clear? I hope you got this, the difference between symmetrical IUGR and asymmetrical IUGR. So, if you see this picture, you will be able to understand. So, this is a picture of a appropriate growth profile baby. Okay, so you see how the head is and the torso is. Whereas in a symmetrical IUGR, the whole size of the baby is reduced from the head to the torso. Okay, whereas in asymmetrical IUGR, what is happening is the growth of the head is somewhat normal, whereas the body has growth restriction. Clear? So, this is another picture. So, where you are able to see a normal baby. This is a normal baby with appropriate growth profile, and this is a baby with asymmetrical IUGR. Okay. So, if you see this, you will be able to see the head is somewhat larger. Okay, when compared to the body. Okay. So, this is the difference between symmetrical and asymmetrical IUGR. Hope there is no confusion at all. Right? Okay. Now, we will pass on to the next classification, that is, what do you mean by early onset IUGR and what do you mean by late onset IUGR? So, if you see early onset IUGR and late onset IUGR, the onset is less than or equal to 32 weeks. Here the onset is after 32 weeks, and remember, early onset IUGR is less common. Okay, so this is only around 30%, whereas late onset IUGR, it is more common. Okay, so this is seen in 70% of the cases. Okay, just like your symmetrical and asymmetrical IUGR. And then if the IUGR is going to happen early, this will be more severe, whereas in late onset IUGR, there will be less severe features. And if the IUGR is happening early, it will be difficult to manage. Okay, whereas in late onset IUGR, there will be difficulty to do diagnosis. Clear? And then usually early onset IUGR is associated with placental dysfunction and hypertensive disorders. Okay, and hypertensive disorders, whereas late onset IUGR all not associated. Okay, usually they are not associated with hypertensive disorders. Okay. So, in early onset IUGR, we will be able to see umbilical artery abnormalities, which include decreased middle cerebral artery impedance. The same thing can be seen in late onset IUGR also. Okay. And so, from now you have understood. So, by now you would have understood that in early onset IUGR, there is early deterioration of the fetus, whereas there is early deterioration of fetus, whereas in late onset IUGR, what is going to happen? The baby can grow normally, but there are increased chance of late unexplained stillbirth. Correct? Okay. Now, so you'll be wondering how this asymmetrical IUGR happens. Why the head is growing normally and why the remaining of the body is alone getting a growth restriction. So, if you see in asymmetrical IUGR, mostly the commonest cause we have seen is there is a uteroplacental insufficiency. So, there is a chronic uteroplacental insufficiency. So, this will lead to so many things. I will explain one by one. One, when this is done, there is reduced amount of blood flow as well as nutrients to the baby, right? So, what does the fetus do now is, the fetus redistributes the blood flow between various organs. Okay, so there is increased blood flow to the brain and the heart. Okay, so the important organs are conserved, right? Whereas there is reduced blood flow in the remaining organs, like there is reduced blood flow to the skin, to the lungs, to the other abdominal viscera, right? And also the kidneys. Okay, so this is very important, because when there is reduced blood flow to the kidneys, what is going to happen is there is decreased amount of fetal urine production, and that will result in reduced levels of amniotic fluid levels, and that will be manifesting as, yes, very good, it is going to be seen as oligohydramnios in your antenatal scan. Clear? Right. And also remember another fact. Okay, suppose when the baby is deprived of the blood supply, it is also going to get deprived of the nutrition. So, what is going to happen? It is going to use the glycogen stores that are present in the liver, right? So, the liver glycogen stores are depleted. So, what happens? The liver span is going to reduce and then the AC decreases. Clear? Yes. Now, we will see how we are going to diagnose IUGR. So, diagnosis of IUGR includes anything you have to start from the history. Yes or no? So, from the history, identify the patients who are at risk for, okay, so risk for malnutrition or low BMI at conception. Then, if there is a increased chance of infections or any infections are diagnosed, and then any renal disorders are present in the mother. Clear? And then you are going to assess the gestational age. Okay, so we have to assess the gestational age, and this gestational age assessment is more reliable by USG than obtaining it by the obstetric history. Okay, so USG dating more reliable than history, and especially when it is less than 20 weeks of gestational age. Clear? Yes. And the third point is you can go for a clinical examination. Okay. So when you have to start examining clinically, you should start examining the uterine height from 24 weeks of gestational age. Okay. So that is nothing but the uterine height or the fundal height. Okay, you have to remember the fact that symphysiofundal height, okay, increases by 1 centimeter per week. Okay, and especially between the weeks 14 to 32, the symphysiofundal height is going to increase by 1 centimeter per week. Okay, and if you have a lag of 3 weeks, it is considered as FGR. Clear? And remember, this has a low sensitivity value when it is used alone. Okay, especially when it is used alone, and it is also difficult to measure fundal height in case of obese women. Clear? So we'll see in detail about the USG evaluation now. Okay, so if you take USG evaluation, this includes you have to study about the fetal biometry, the placental morphology, amniotic fluid volume, okay, and the Doppler. Clear? So we'll see about the fetal biometry first. So if you take fetal biometry, you have to study about the biparietal diameter, HC, AC, femur length, and fetal weight. Clear? So you have to see the BPD, and when it is having a growth rate less than 15 percentile, then it is a FGR baby. Similarly, when the HC you are considering, this is a better marker than biparietal diameter, and remember, this is not subject to variability. Clear? And then you have the AC. So this is the most accurate fetal biometry measurement for diagnosing FGR. Okay, most important. Clear? Because we have seen the reason already. Okay, then if there is an increase in fetal AC less than 10 millimeter in 14 days, okay, then you can make a diagnosis of intrauterine growth restriction. Clear? And also I have to mention about another diameter here, that is transcerebellar diameter. Okay, so up to 25 weeks, okay, the measurement of transcerebellar diameter in centimeters is equal to the gestational age in weeks. Okay, so this is transcerebellar diameter in centimeter is equal to the gestational age in weeks, and this can be done up to 25 weeks of gestational age. Clear? Okay. Now, we also have some ratios. Okay, so the commonly used ratios include HC AC circumference, which will be increased, it will be increased to more than 2 standard deviations, and then femur length by AC circumference, this also will be increased, and it will be increased more than 23.5%. Clear? Now, how do you calculate fetal weight? So, if you take fetal weight, all the calculated parameters including BPT, AC, HC and FL, all these can be used to calculate the fetal weight. Okay, you have so many formulas like Hadlock's formula, Shepard's formula, etc. Clear? Okay. Now, we will see the placental morphology. So, when you take the placental morphology, in IUGR and PAH, the placental morphology can be seen in the later stages because there is an increased rate acceleration. Okay, there is an acceleration of placental maturity. Clear? Then we will see about the amniotic fluid volume. So, amniotic fluid volume usually, I have already told you, asymmetric IUGR is associated with oligohydramnios, right? That means AFI is going to be less than 2 centimeters. Clear? Okay. Now we will see how we are going to follow up the IUGR cases. Okay. So, we are going to consider the risk factors first. Okay. So, according to the risk factors. Okay. Suppose if you find in the first trimester there is minor risk factors or seen, more than or equal to 3 minor risk factors, and there is at least one major risk factor. Okay, so now we'll see how we are going to follow up these patients. So following up can be designed based on the risk factors present. So I'll take the first category where there are minor risk factors around more than or equal to 3 minor risk factors. Okay, so what is going to happen is that you have to follow them with uterine artery Doppler around 20 to 24 weeks. Okay, then you have to check whether it is normal or abnormal. Say it is normal, then you have to assess the fetal size and umbilical artery Doppler. Clear? Suppose if it is abnormal, okay, if it is abnormal, then you have to go for a serial assessment of fetal size and umbilical artery Doppler from 26 to 28 weeks. Clear? Right? Okay. Now, let us say about the major risk factor. Suppose if you have even one major risk factor is considered to be a high risk. So, what you should be doing is basically you should be reassessing the other risk factors also. Okay, other major risk factors also. For example, if whether the papa is low or there is a fetal echogenic bowel, like that you have to reassess. Okay, and this should be happening in the second trimester. And when it comes to the third trimester, what you will be doing is, you will be going for the same thing. That is, you will be going for the serial assessment of the fetal size and uterine artery Doppler from 26 to 28 weeks. Clear? Okay. Suppose if you have women in whom SFH cannot be measured, for example, if she is obese or if there is a large fibroids, in that case what you will do? You will directly go to the assessment of Doppler. Okay, so serial assessment of the fetal size and uterine Doppler, you have to do it from 26 to 28 weeks. Is that clear? Can you understand? So once again, I will repeat this alone. So when you have minor risk factors, that is around 3 or more than 3, then if you find these risk factors in the first trimester, then ideally you have to start assessing it from the second trimester itself. You have to do uterine artery Doppler in 20 to 24 weeks around. You have to do the uterine artery Doppler, and if it is normal, you have to continue follow up the fetal size and umbilical artery Doppler in the third trimester. Suppose if it is abnormal, then serial assessment of the umbilical artery Doppler should ideally start somewhere around 26 to 28 weeks itself. Clear? The same way, if you have one major risk factor, check for the other major risk factors also. Okay. Then you have to directly start assessing the umbilical artery Doppler from 26 to 28 weeks. And also in women with obesity or large fibroids, you have to start serial assessment of the umbilical artery Doppler from 26 to 28 weeks. Is that clear? Yes. Now, see here, you have to understand the fact that the normal pregnancy, okay, in normal pregnancy, there is usually a low resistance feto-placental system, and there is continuous flow of blood throughout the cardiac cycle. Okay. So, what is happening in uteroplacental insufficiency is that there is a damaged tertiary villi capillary bed. Okay, so this is found to be damaged. Because there is damage, what is going to happen? There is increase in resistance in the blood vessels. So, there is increased resistance in placental blood vessels. Clear? Also, there is a decreased umbilical artery blood flow and increased ST ratio. Clear? See, normally the ST ratio of umbilical artery, okay, I am speaking about the umbilical artery here. ST ratio of umbilical artery is less than 3. Okay, and if ST ratio of umbilical artery is more than or equal to 3, then there is uteroplacental insufficiency, which means there is a fetal growth restriction. Clear? So, usually you have to understand the fact that umbilical artery Doppler changes are the first Doppler changes that you will be seeing in case of fetal growth restriction. Is that clear? See, this is a picture of umbilical artery Doppler where you are able to see a normal waveform with a normal SD ratio. Okay, I'll just zoom it. Okay, normal waveform with a normal SD ratio. And here if you see there is an increased impedance to flow with abnormally elevated ST ratio. Okay, and here there is an absent diastolic flow. So, this is the systolic flow. Okay, and this part is going to represent the diastolic flow. So, if you are able to see here, there is no diastolic flow at all. So, that is absent end diastolic flow, and here what is going to happen is there is reversed end diastolic flow. Okay, so what does that signify? Okay, so reduced diastolic flow means there is 30% of the vasculature got destroyed. Okay, so in absent end diastolic flow, around 60 to 70% of the vasculature would have got destroyed. And when you see reversed end diastolic flow, you have to be very cautious because you can expect fetal demise in another 1 to 2 days. Clear? So, that means significant it is. Remember, it is first absent followed by reversed end diastolic flow. Okay. And also remember another fact that in normal pregnancy, what is going to happen? There is equal distribution of blood to all the organs, right? So, what is going to happen in IUGR or uteroplacental insufficiency? What I have said to you? the major organs are protected like the brain and the heart. So that is also known as brain sparing effect. Okay, so the brain is spared from the IUGR effect. Okay, so what is going to happen here is the ST ratio reduces in middle cerebral artery Doppler. Okay, also the resistance index and pulsatility index also reduces. Okay, another ratio is cerebral placental ratio, which is the ratio between middle cerebral artery pulsatility index and the umbilical artery pulsatility index. Okay, so here if you see a ratio less than 1.5, okay, then it is found to have adverse outcome. Clear? Right. So another point you have to know, also we know that in normal fetus, the flow in ductus venosus is going to be normal, right? So what happens in IUGR? The ductus venosus waveform, okay, shows absent or reversed blood flow. Okay, that is, it will show fetal acidemia or even death. Clear? So let me summarize the changes what is going to happen in FGR once again. Okay, so first there is a decrease umbilical venous volume that will be resulting in reduced liver size. That means there is a reduced abdominal circumference and there is an increased uterine artery Doppler resistance, and following this there will be flow redistribution, okay, to middle cerebral artery, and during this time only we will be anticipating the brain sparing effect, and that will result in reduced amniotic fluid volume, and this can be seen as oligohydramnios, and this will be followed by absent end diastolic flow in umbilical artery, and then it will be even changing to reversed end diastolic flow in umbilical artery, followed by your ductus venosus change will be seen. In the ductus venosus, you will be having A wave to be absent, and what happens is the biophysical profile will also decline, and during this time there can be a non-reactive NST that can be associated with the decelerations, and finally all these things can result in fetal death also. Okay, let me summarize it once again. So first, there is a reduced umbilical venous blood volume that will be resulting in reduced liver volume, which will be reducing the abdominal circumference. So abdominal circumference reduction is the first thing that is going to happen in IUGR. Okay, then it will be followed by umbilical artery resistance, which is going to be increased. Then flow redistribution to middle cerebral artery will be happening, that will be associated with brain sparing effect. There will be reduced amniotic fluid volume, absent end diastolic flow, then reversed end diastolic flow, that will be followed by change in the ductus venosus, where the venous waveform, that is A form, is going to be absent, and then it will be resulting in biophysiological profile decline, which will be associated with non-reactive NST or NST with the decelerations. And finally, when you see all these things, you will be anticipating the fetal death very soon. Clear? So this is how the FGR is going to progress. Okay. And most importantly, you have to do a fetal anatomic survey, because know that 10% of FGR is associated with congenital anomalies. Okay, and we have some association with biochemical markers also. Remember, these are not used for diagnosis. These are considered only high risk. Okay, so biochemical markers which are considered as high risk include a low papa value in first trimester, and then in the second trimester you will be having increased HCG values, inhibin values, or alpha fetoprotein values. Clear? Okay. And in some cases you may even need some genetic studies. Okay, like when there is a early symmetrical IUGR. Okay, right. Now we'll see the management part. So when you see the management part, we'll be considering three factors here. Number one is fetal monitoring. Okay. Number two is maternal interventions needed. Then when to plan delivery. Clear? Okay. Now we'll see the fetal monitoring part. So what is needed here? Mostly fetal monitoring can be done with the outpatient management itself, and hospitalization is considered only when there is a absent end-diastolic flow or reversed end-diastolic flow, and if there is a need for daily BPP. So if these things are present, then there is a need of daily biophysiological profile calculation. Clear? So what will be dealing with the, how you will be dealing with the, repeat. So how you will be dealing with the growth scans? So when talking about the growth scans, you have to do a serial USG every 2 to 4 weeks for growth velocity. Then estimated fetal weight is plotted on a growth curve chart. Okay, so when you plot this, it will be helpful in differentiating between the FGR baby and a constitutionally small fetus. Okay, so to differentiate between the FGR and a constitutionally small fetus. Okay, then what you will be doing? You will be doing definitely a Doppler study, because we have discussed so many changes with the vessels, right? So Doppler study, when umbilical artery Doppler is normal, then Doppler should be planned at least once in 2 weeks. Clear? Okay, and you have to keep a check on the following factors, that the estimated fetal weight should be more than or equal to 5th percentile. They should have a normal growth velocity and normal amniotic fluid index also, and there should not be any associated maternal risk factors. Okay, suppose if you have the umbilical artery Doppler systolic diastolic ratio is more than or equal to 3, then you have to do this Doppler every weekly. Clear? Also, if there is absent or reversed end diastolic flow, then it necessitates the need for delivery. Okay, you have to, however, consider the gestational age as well as the biophysiological profile. Okay, if needed, you can even consider the ductus venosus Doppler waveform. Clear? Yes. Now, at what frequency you should do this NST and biophysiological profile? See, NST and biophysiological profile is not needed regularly or at a planned intervals when the Doppler seems to be normal, growth velocity is normal, okay, and there is no other maternal risk factors and there are no signs of uteroplacental insufficiency. Clear? But it should be done twice per week. Okay, when there is some risk factors like preeclampsia, which will result in uteroplacental insufficiency, or oligohydramnios, which is a manifestation that the process has already started, then there is a severe FGR. Okay, so in all these cases, you have to do NST or biophysiological profile twice in a week. Okay, and remember, this is needed daily. Okay, when? Yes, tell me, when you have to do daily? Yes, when there are change in umbilical artery Doppler, like there is a absent end diastolic flow or reversed end diastolic flow, you are going to repeat it every day. Clear? Now, so we have seen how we are going to do the fetal monitoring. Then we'll see what are the maternal interventions we have to do for fetal growth restriction. Clear? So, maternal interventions include antenatal steroids can be given between 24 to 34 weeks. Okay. So, this is given because there can be a chance of uteroplacental insufficiency happening, So, this is given because there can be an anticipated need for delivering the fetus earlier in the gestational age itself. Okay, so antenatal steroids can be given, but definitely there is no role to support your low dose aspirin or bed rest or anticoagulation, oxygen therapy, and even plasma volume expansion. Okay, so remember, these things are not recommended. Only maternal intervention you can do is you can give antenatal steroids between 24 to 34 weeks. Clear? Okay. So regarding delivery of the baby, we will be planning immediate delivery. Okay, when the ductus venous waveform is absent, okay, at any period of gestation, okay, at any gestational age, and there is reversed end diastolic flow that is happening more than or equal to 32 weeks of gestational age, or there is a absent end diastolic flow which is seen at or above 34 weeks of gestational age. Clear? And also remember that suppose if you are seeing this reversed end diastolic flow less than 32 weeks or absent end diastolic flow less than 34 weeks, then what you have to do is you will be doing a daily biophysiological profile till 32 to 34 weeks. Okay, so accordingly, for reversed end diastolic flow 32 weeks and absent end diastolic flow 34 weeks. Okay, and any time, okay, while monitoring this, anytime if there is any changes happening with the ductus venous Doppler or if there is any abnormal parameters seen, okay, so abnormal parameters with these profiles or there is a absent ductus venous Doppler seen, then you will be planning for, yes, immediate delivery. Clear? Right. And also remember, administer steroids if it was not given previously. Understood? Okay. Now, we'll see the decreased diastolic flow. Okay. So, what will you do when there is a decreased diastolic flow alone? In that case, you will be doing biophysiological profile twice per week. Okay. Then, you have to deliver the baby at term. Around 37 to 38 weeks you have to deliver the baby, and then if biophysiological profile is abnormal, definitely you will be going for a immediate termination of the pregnancy, that is immediate delivery. Clear? And the next thing is, suppose if you have a normal umbilical artery Doppler. Okay. So, in this case, you can plan delivery around 39 to 40 weeks of gestational age. Clear? So, this is all about fetal growth restriction. I hope you understood this topic well. So, until we meet in the next video, take care, happy learning and bye-bye.